No. We're going to try that again. Good morning, everybody. Good. Now, that sounds like a Pratt City good morning. It's good to have you here this morning for part 2 of What's Breaking My Heart. You know, when Howard first told me about this theme of what's breaking my heart, I immediately thought about that yellow girl that broke my heart when I was in high school, my first love. That's why I said, Lord, I want a wife that's jet black. No, and those of you who know my wife know the Lord answered my prayer. We're just glad to have you here this morning. You know, the Bible says that faith without works is dead. And the faith part of this says, I trust the Lord to take care of me, and I know God is in control. That's the faith part. But here's the works part. See about yourself. Go to the doctor. Take your medicine. See about yourself, because faith without works is dead. Now, if you put it in a mathematical form, faith minus works equals something we don't want to talk about. So let's do the work that we need to do so that we can postpone that last part, because like I said last week, I take no pleasure in preaching funerals. I want my folk to live a long time. I told my wife, I'd rather you bury me than me bury you. I want us to live a long, healthy life. So let's do the work, and let's listen to this great panel that has been put together today and get as much as we can so that we can live a long time, all right? A long, healthy life. Is that all right? All right. This year we gave awards to our members who were nonagenarians, and nonagenarian is a person who has passed 90 years old. So next year, I want to add to the group of nonagenarians. Amen. And if the Lord be kind, we'll have one to enter into the group of centurions, because she's 99 this year, and if she lives a little longer, she'll make 100. And that's what we're trying to reach. So let's give a hand to Dr. Tuckson as he comes and presents our agenda for today. Let's give him a big hand, y'all. Okay, we got to do the morning prayer. All right. Thank you for reminding me to pray. All right, saints, let's bow our heads. God, we thank you for today. We thank you, Lord, for sparing us to be here today and to witness this great occasion. Now, Lord, I pray that you would bless our efforts here today. Touch every speaker. Lord, let them speak from the vantage point of not only science, but love. Oh, God, we just ask you to bless our coming together today, and let the fruit of it be a healthier, happier people who can spread the word that we need to take care of our hearts. Thank you, Lord, for hearing our prayer, and we claim the blessings in Jesus' name. Amen. All right, Dr. T, let's give him a hand now.
Thank you very much, Dr. Hammonds. It's always so good to hear. And thank you again for opening up Antioch Missionary Baptist Church to the Heal and to this program. For those of you who were here last week, you remember we talked a couple of things. There are two diagnoses we never make. Number one is the one we don't know about. Number two is the one we don't think about. Well, from what we heard last week during part one of our program about what's breaking my heart, we can't say we don't know about this anymore. We heard a little bit last time about heart disease in general, some of the things that affect us as far as the heart, some of the symptoms that are going on as far as the heart. We noted that there are a lot of problems with exercise and dietary patterns are significant factors as far as heart disease. Then we heard a little bit about a particular problem called amyloidosis affecting the heart. A very unique problem. And remember, we had people up here who had multiple members of their family who were affected by cardiac amyloidosis. So we learned about the importance of genetics in terms of transmitting this disease and how to use genetics to identify individuals who are going to be at risk. And then finally, we talked about some of the things, again, to be aware of what this diagnosis carries. So hopefully we're going to try at this time to go forward with this with a few other different perspectives, talking about what goes on as far as lung disease, how to get into cardiac programs to make sure people are following you, looking at some of the medications that we're taking, and also we're going to take a little bit look at how we can do a little bit of exercise without having to be too strenuous about this, but some of the things, and then finally talk about some dietary recommendations for all of us. I want to remind you that in your programs you have little sheets that are for pre-survey and post-survey. Please be sure to fill out the pre-survey so that we can have that information. And then at the end of the program, we want you to fill out the post-survey. And please turn those into us so we can kind of keep record and know what people are saying. So again, there's the pre-survey and then there's the post-survey. Do the pre-survey now. After each one of our speakers, they'll sit back down, but at the end of it, we're going to have a question and answer session. So please write down any questions or comments that you want to make, and we'll take those when we do that at the end of the program, the question and answer session. Let me begin we get some welcoming remarks first from Mr. Howard Mosby. Mr. Mosby earned his bachelor's degree in business administration and finance from Georgia State University, that's Georgia State, not Georgia Southern, and then completed the University of North Carolina School of Public Health Management Academy. For 8 terms, he represented the 83rd District of Georgia State House of Representatives. He is a founding member of the HEAL Collaborative and serves as both the corporate treasurer and the interim chief operating officer. Mr. Mosby, please.
Good morning. It is indeed a pleasure to be back here with you again. This is important information that we want to make sure that our community brings to you. HEAL Collaborative, really, and you all know us, we want to make sure that we put our arms around you, that we want to bring information to our community. It is imperative that you have this information, and sometimes when you're sitting in front of your doctor, you don't have enough time to be able to ask questions that you want to get answered. So we're bringing these subject matter experts in front of you so you can ask the questions that you want to get answered. And please take advantage of this opportunity. This is huge for us, and it's huge for you to be able to get information that you can actually use to help you live a healthier life. We're indeed honored to be here today. We're honored to partner with Antioch. Bishop Hammonds has been a good friend. He has opened his heart, his house, and his you all up to us to bring this information. So we're proud to be here. We want to do you a good job, sir. That's what we are trying to do. I want to also thank, I know they were coming to do their own introduction and welcome, but AstraZeneca is also a major multinational multi-billion dollar corporation that is in your house today because they also want to see you be healthy. And so we're here today to make sure that that happens. So with that, did I take enough time? Because we're trying to make you fill out the survey, so I'm filibustering. Can I talk to the gentleman from the 83rd? You can stand up. No, okay. So thank you very much for all you do. Thank you, Dr. Tuckson, for all you do.
As Mr. Mosby stated, this is a partnership with AstraZeneca. And before I bring up Dr. Pasha, we have a couple of representatives. Alessandra, Paul, would you two please stand up So we recognize also some representatives. Thank you very much for being part of all this and being here with us today. Our next bring up Dr. Evan Pasha. Dr. Pasha graduated from Skidmore College with a BS in exercise science, and then he went to the University of Texas at Austin, where he earned his PhD in kinesiology and exercise science. Dr. Pasha then channeled his inner Michael Jackson at the 2025 Denton United Way's Dancing with Our Stars event. Not only did he do his dancing, he won the Judge's Choice Award. When Dr. Pasha is not dancing, he is the medical science liaison, medical affairs with AstraZeneca. He will now come up here, bust a move, and give us a welcome.
I don't know, it's gonna be a little hard to moonwalk up here, the carpet, so I'll save the moves for another time. But thank you, Dr. Tuckson, and you know, super grateful to be here. My role within medical affairs with AstraZeneca is essentially to be an educator, and I come from a family of educators. Both my mom and my dad are teachers, and I try to help educate these clinicians about the most current science and health and unmet needs that are within the community. And so super grateful to be here and part of your congregation today to get a better understanding of you know, the needs that are present within the community, so I can better educate clinicians around Birmingham, around Alabama, and serve on your behalf. So really appreciate being here, and thank you all so much. Yep.
To get us started today, we're going to do a little warming up with Fitness for Life. We have with us today Dr. Brianna Richardson. Dr. Richardson is a physical therapist with M3 Endeavors. She graduated from the University of Alabama, where she obtained her BS degree, and then she got her doctorate in physical therapy at Alabama State University. Now, we don't want nobody having a heart attack. We're talking about heart disease, but we want to talk about some of the things we can do to keep us healthy. Dr. Richardson.
Good morning. Thank y'all for having me. I'm excited. Well, let me turn this down just a little bit. Is that better? Can y'all hear me? Okay, good. So like I said, I'm going to take y'all through a warm-up. These movements are going to be just some really simple things that you can do if we're sitting at home, if we're working from home, if we're working. Things that just keep our body moving so that we don't get stiff and achy, and that we just keep being able to live and do what we want to do. So I will ask I know we love our neighbors, if we can scoot just a little bit, because some of these are going to have our movements that go out to the side. So if you're sitting right next to somebody, just take a second to get an arm's length away. All right. So I'll ask everyone also to scoot a little in the pew, just so we're not resting, so we can have good posture sitting up nice and tall. Apologize for the static. I don't know what I'm doing wrong, but we'll keep going. Okay, so nice rested shoulders. We're going to start with just rotating our head. So getting our neck nice and warmed up so we can look and see what's going on around us throughout the day. Good. One more time each leg. Good. Now we'll look down towards the floor and then up at the ceiling. Taking our time, working through the available range of motion that we have. Don't force anything. Good. One more time, down and up. Good. Now we'll tilt our ear to our shoulder. So notice I didn't say bring your shoulder to your ear. So don't shrug it up. Just going over to the side. Still not forcing anything. Just go where you can go. If your neck pops a little bit, that's okay. Mine's cracking. You just can't hear it. Good. One more time, going each way. Good. From here, we're going to shrug our shoulders up to our ears and then press them down. Good. Towards your back pockets. Up to your ears and then down. Good. Two more times, going up. Last one. Good. Now we're going to take our arms, press forward, and then pull them back, squeezing your shoulder blades together in the middle. Good. Pressing forward, squeezing your shoulder blades. We're going to try not to push anybody. Good. Make sure when you're pulling your arms back to squeeze that we're not shrugging up here, so we're not in our ears. We're pulling back, keeping our shoulders down. Good. Last one, pushing forward. And good. From here, keeping our arms, we're going to press up and then pull down. Pressing up and back down. Again, just working in your available range. If that's not available to you, that's okay. Just go where you can go. Good. One more time, going up and then down. Now, arms are up to the ceiling, crossing the arms across your abdomen and then rotating them away. Good. Keep going. Arms down. Moving down to our legs now. We're lifting the heels and then lifting the toes. So if you need to kind of bring your feet forward, that's okay. Lifting the heels, lifting the toes. Still sitting up nice and tall. We shouldn't be resting on the pews. Good. Two more times. And again, these are really simple to just do throughout the day. If you find yourself sitting, if you work from a desk, if you're sitting at home watching TV, these are all good to just keep moving, but they're not super strenuous, so anybody can do them. Good. So this last one sitting down. We're gonna march our leg one at a time. Now the trick with this one is you don't want to lean and twist. You want to try to stay upright and still. So if you can't bring your leg up without moving, don't bring it up that high, but just trying to stabilize, working on our core and our hip flexor muscles. Good. One more on each leg. And then the last one, I always encourage people not to sit down all day. I like to have people stand up at least every 30 to 45 minutes, especially, again, like I said, you're standing at least once an hour. So we're all going to stand up and sit down together both times. Ready? Standing up nice and tall, and then controlling on the way back. Good. Standing up nice and tall, controlling on the way back down. Good. Stand up nice and tall, and then controlling on the way down. Good. More than 3, then gonna, I don't know why the mic is not loving me, but try to do at least 10 sit to stands every day, and that'll help strengthen your legs and keep you strong.
Dr. Richardson, most of us were doing the exercise one way, but there was one brother who was getting more out of this exercise than any I've ever heard. I needed that. I mean, by the way, Dr. Richardson's going to stay with us to the end so we can have, but we'll have some information how you can contact her so you can get more of this type of training. I know others, especially my brother over here, Pastor, I tell you, I heard people feel in the spirit, but man. That's pretty good. But the holiday like on Sunday morning. I guess it depends on what happened Saturday night. Now, our next speaker is Dr. Eric Flano. Dr. Flano graduated with honors from the University of Texas Health, Houston, and the Government Medical School. He then completed a residency in internal medicine and a fellowship in pulmonary and critical care medicine at the University of Texas Health Science Center in Houston and at the MD Anderson Cancer Center. Dr. Flano is an associate professor in the Department of Medicine at Morehouse School of Medicine in Atlanta, and he's chief and director of pulmonary and critical care and interventional pulmonary medicine at Grady Hospital. He's also the director of the Georgia Cancer Center, Advanced Diagnostic Interventional Pulmonary Service. He's also director of the Lung Nodule Clinic at Grady Hospital. Today, Dr. Flano will address managing the impact of amyloidosis on your lungs.
Good morning.
Good morning.
Speaking close enough? Morning. Sorry, speaking. I'm glad that we met. Right. Last year we came through and we talked about lung cancer. This year I'm going to talk a little bit about amyloidosis in the lung. I know last week you had hearing you talk about in terms of cardiac function. I'm a little bit jealous now because of the lungs. We always argue over that, but there is an impact. If you think about how the interplay between the heart and lungs are, 90% of the blood coming back to the heart, or 95% actually has to go through the lungs and come back. So I want them to look at this and see, do we have the slides? Here we go. All right. So not going to be so overwhelming. It's going to be the general overview because as we've learned more about this disease, the amyloidosis, and affecting we're also starting narrative actually impacts the local cell in the relationship between the two. Next slide. So just sort of a recap. Remember this thing, amyloidosis is a rare disease, right? But it's not as rare as we thought it was in the past. More testing, more genetic recognition, we're actually starting to find it more. It can affect multiple organs at once, not just the heart. It can impact the lungs, it can impact kidneys. The more we start to learn about it, the more we see there's an interplay between all of these organs in this disease process. And when there is so much overlap of the disease, the organs that are affected by this disease, then the symptoms start to mimic each other. So we really have to pay attention to some of these symptoms because the earlier we diagnose, the better the outcomes are. Next slide. So just to recap, I know you guys had very good talks last week, so I'm just going to run through a little bit of a recap about what exactly the amyloidosis is. So what happens is you have normal proteins in your body that are made, and then a lot of times your body can clear those out. But when the proteins are abnormal, they're misformed, they become a little bit rigid, and then they collect together, and it's hard for your body to get rid of those. And these circulate through the blood, and they find themselves depositing in different organs. That's like, yeah. And what can happen is you start to get symptoms of related to the organs that they deposited. You can get dizziness. You can have your blood pressure be elevated. You can get stiffness in the heart, which makes it hard for you to exercise and to breathe. It can impact the kidneys and give renal failure. We also start to see more and more as we look into it, it impacts the lungs, and that actually impacts the breathing as well. And if not done breathing, these symptoms can be life-threatening. Next slide. So, recap what you heard last week. They talked about the amyloid deposits in the heart. And a lot of times, the developments of heart failure, a lot of times when you start thinking about heart failure, you think that the heart gets weak and it gets dilated and it's not pumping as well. The difference here is when these fibers start depositing themselves into the heart, they get in between the muscles still, and it builds up and becomes bulky. So on the right-hand side, on the left-hand side, you see where the heart is meeting, right? And then as you go to the right, you see the other picture where now you see the walls, the length of the heart looks really thick because these fibers have come in there. And that keeps it from actually filling up and pumping as much blood. It also slows down how the induction of your heart rhythm goes through. So people start getting irregular heartbeats. And these can actually be life-threatening. In next slide. Next slide. And just a little, just an example of how this works. So if you look towards the left-hand side, those are normal heart muscles. Do you see the paint-colored stuff? That's the amyloid in actual heart muscle. And so you can see that this person, unfortunately, that cross section is taking up about 50% of the heart muscle. So it makes it more bulky, less effective in its ability to pump blood. Next slide. Next slide. I'll go back on. I'm sorry. I don't. Gotcha. So what exactly is pain? Go back again. You can't. It's true. Bang. Go back one more. Because if we can't go back one more, I think that's going to be. So what exactly is pulmonary amyloidosis? When it starts impacting the lung. So you think about these fibers that are floating through the bloodstream and depositing themselves, getting captured. Well, 95% of the blood that your heart is pumping each minute goes through the lungs. Then a lot of these fibers are going to get trapped in the lungs. And we didn't realize this a long time ago until we started paying more attention to this disease with the heart. And so, well, why is the lung not being affected? Well, it actually is. So in this picture here, you'll see that is an amyloid lung. So you see the big open spots of holes. Those are your areas, that's where air comes in. And they're supposed to be very close together. There's kind of difference in between, and that's where oxygen comes in and carbon dioxide goes out. But now when these fibers start filling it in, and it gets thickened like that, now you don't get oxygen across very well, and it actually starts to make the lung very sick. That makes the breathing really hard. And over time, this sort of builds up and it becomes unrecognized. One of the reasons it becomes unrecognized is because people misinterpret or don't react to the symptoms that they feel they're often the same way. So if you think if the oxygen is not getting across very well, you're going to get very short of breath. But what happens with people when they get short of breath, and the first parts of it in those early times, they stop doing as much. Right? And so they don't pay attention. Oh, yeah, I used to walk down the street. No, it's just kind of about, you walk to the edge of the driveway, and it sort of creeps up rather than actually paying attention to what's going on inside of a rock. And over time, it gets worse and it gets worse. And then this impact in the lungs can actually back up and start influencing what's happening with the heart. Next slide. And you can see it can present in several different ways. So these are CAT scans of the lung. And if you look on the left-hand side, you can see the little white spots in the dark areas. So like dark areas look normal, as your heart in the middle, whatever else. And you see the little white spots popping up. So that's just a cluster where this amyloid develops. Now, if you were here when I talked last year, you'd say, well, that might actually look like a cancer because it can mimic it, just not a CAT scan. So it's important to get that diagnosed and exclude the diagnosis of lung cancer. But when you see that as it progresses, you get more and more of them developing. If you look on the right-hand side on the top, slide B, there's a lot more haziness to it. That's because in all the little air sacs around there, all these fibers are deposited, and it starts to get thickened and over time they start to coalesce. And that's when patients really start to get trouble with breathing, trouble with exertion. They might have a persistent cough. Next slide. And so these symptoms develop over time slowly, and then start thinking, okay, well, maybe it's just asthma that you have. Or maybe I just have a cold that's not going away. And then over time, you can start getting symptoms where there's a very common symptoms to other disease processes. Even with cancer, you can cough up blood. With amyloidosis in the lungs, you can cough up blood. And you start to lose weight. You start to get fluid retention. And before you know it, you have this point in time where it's just creep up, and you hit this crucial point where you can't do much at all. And that's you really need to start thinking what's going on inside of your body and get this diagnosed. And especially for those patients that may already have a diagnosis of amyloidosis, whether it's the primary type where your body overproduces some of these proteins and can't keep up with the breakdown of them, or if it's the hereditary type, where you inherited a gene that causes the overproduction of these proteins, which is present in about 3%, 4% of African Americans. It's not recognized, now we recognize this map. Next slide. And so the conditions that it affects are entirely different in terms of the actual presentation. So I'm showing you what happens with pulmonary amyloidosis on the left-hand side, and on the right side, it's cardiac. So on the pulmonary side, there's three major ways that this can impact or present in the lungs. So on the one very far over, which is a little bit pushed off on the slide, but it's A and E, you'll see that they're looking at the throat and the airways. And then where it should be nice and smooth, you can see little lumps and bumps of it on the actual picture of it. These are amyloid deposits that happen inside the lungs. And so what does the patient feel when they have that? It starts to close off the airway. If you want to know what that feels like and these symptoms feel like, the next time you're at a restaurant and you get a straw for your drink, put the straw in your mouth, you drop your nose, and walk around and see what it's like to breathe, because those are the symptoms that the patient will say. They feel like I'm breathing like I'm breathing through a straw. The other part, we see the nodular, but if you look at the pulmonary, it says G and H. You'll start to see, especially on H, it looks like it's just really, all this little fibrous things reaching out and taking over the lung. That's where you start to really have the symptoms, where the lung starts to get stiff. And so now when you talk to somebody, say, well, yeah, when I take a deep breath, I can't get the air in. I can get it out, okay, I can't get it in. And that's where you have the problem, because the lung becomes still, it becomes limited in terms of function. Very similar to what happens in the heart. If you look at the heart models, you see the drawing, and then immediately to the left, that's normal heart, normal muscles, and the chambers up there. But if you look to the right-hand side, that's where you see that the walls get thickened, it's infiltrated in there, and doesn't pump as well. And an MRI below shows the heart there, it's very thick wall in the center there. It's very similar to what's happening as deposits are thickening that tissue and making them not crossing it back. And there's an interplay. Next slide. So the diagnosis is usual, recognizing the symptoms and pursuing, and they're bringing it up and suggesting maybe you're doing a diagnosis. When we see that thickening on the left-hand side, you see that pain, that's all those fibers that are clustered into the lung. There should be a lot of open air space there. It's taken over. when they do the special stage, you look about this on the red, it stains all those little EJ stains right there on regular way. This letting of the call able to say a ton cream or the fucking days. But that's the fibers that are developing. It's the same way with the heart. When they get the special stain there from the normal from the biopsy, and then they stain it there, you can actually see where all of these amyloid proteins have been infiltrated into the tissue the same way. And so now if you think about the interplay between the lungs and the heart and the blood flow through each of them, now you can hear blood moving through the heart. And you can hear now blood moving through the lungs to pick up oxygen and get rid of carbon dioxide here, and going back to the heart to get to the rest of the body. And that's where things start to spiral down. Next slide. So, what's the interplay between both of them? It affects both organs, and it can affect both organs at once. And one of the more common things, you get this toward the symptom from the lungs being impacted, you'll get the fatigue from the heart being impacted. It can cause your heart to dysfunction. Fluid can build up. It backs up. From the heart, it can back up into the lungs, making the process worse. For the lungs, it can back up and get the fluid in the rest of the body. Your legs are swelling, your tissue not swelling from that standpoint. And then, as it moves on, the blood pressure in the lungs, because it's so stressed, it doesn't have enough oxygen there. It makes it hard to pump blood through. So it makes the heart on the right side fail. And that's when you really get a lot of fluid backing up and building up into the rest of the body. And this is more common, you see this more common with the hereditary one. But what I mentioned, about 3 to 4% of African Americans have, right? And so they'll get this development, it'll start involving the heart, it'll involve lung, they'll get sternal breath, they'll get chest.
Did I do something? Okay, gotcha. The fluid will to build up in between the lung and the chest wall. You start to get thickening of the lungs, limiting your ability to do as much as you were in the past. And the best way to get that diagnosed is to bring up, 1, the symptoms to your physician. 2, they'll get an imaging, whether it's a CAT scan or a chest x-ray, and then pursuing a biopsy to confirm the diagnosis. Next slide. The treatment options for the lung, it's not as studied. We're starting to find more and more about the lung aspect of it. I think a lot of it focuses on just a lot of the symptom control, especially as it pertains to the cardiac. I know you guys had a very good talk about this last time, so I won't dwell into it. But especially with the cardiac components, if you can control the symptoms and the function of the heart, it'll offload the symptoms that are occurring in the lung. And then they can work in terms of new target therapies for amyloidosis, whether it's for the primary type, the AL, which is some chemotherapy drugs or some stem cell treatments to replace the abnormal production from the cells in the bone marrow, or if it's antibodies to help collect and break it down. And then there's new treatments to slow the production, slow the progression. And now they even look at genetic editing, where they can actually identify some of the genes, especially the hereditary types, and make changes so that the development stops. Next slide. So just a brief talk about how the relationship between the heart and lungs are. Okay, it's rare, but early detection matters. And a lot of the early detection means recognizing what symptoms you're having or what risk factors you're having and bringing them to your primary care doctor. Keeping in mind, if you know somebody or if you are somebody that has cardiac amyloid, to bring up and, hey, maybe we should look at the lungs as well, just to make sure that there's not an overlap with this system. And because that can make some of the, especially the way the symptoms overlap, it can make it tricky to make the diagnosis. And if you're having persistent symptoms despite the treatment that you're getting, then bringing it back to your doctors, and so they can look into new things and actually look into some of the clinical trials going on that are focusing on diagnosing the treatment and new therapies for amyloidosis. Next slide. And that's it. Thank you.
Thank you very much, Dr. Flano. Our next speaker is Dr. Pauline Long. Dr. Long graduated from the University of Montevallo with a Bachelor of Science degree in biology, and then she earned her Doctor of Pharmacy degrees, I might add, with honors, from Samford University and McWhorter School of Pharmacy. Dr. Long is on the board of directors for the Minority Women Pharmacists Association, and in 2018, she co-founded Meds Plus Consulting, a healthcare consulting firm that provides personalized, comprehensive health and wellness services to patients, caregivers, and to providers. Today, Dr. Long will speak to us about medication management, ensuring the safe, effective use of medicines for heart disease. Dr. Long.
Good morning, everybody. First of all, it is an absolute honor to be here today, especially with our colleagues in the healthcare industry. Thank you, Bishop Hammonds, for inviting us in, and to Hill Collaborative and AstraZeneca. Thank you so much for inviting me to speak here today. So I am a pharmacist by education and training. I also pride myself on being a community health pharmacist. So many of you probably visit a pharmacy a couple of times a month to pick up your prescriptions and maybe talk to the pharmacist about different things. I did that for 21 years. And after that career, I decided I wanted to be more intentional about reaching into the community, standing side by side with people, helping them live better lives and healthier lives. And so that's when Meds Plus Consulting was born. And we've been doing this now for 6 years strong and very excited about what the future holds. I wanted to take a moment to briefly talk about the importance of medications in heart disease. And I don't have any slides because I really wanted this to be just information that we give you to help you know what's in front of you. So many of you probably once a week do that 7-day pill pack where you're trying to organize your medications, making sure you take them properly. My goal is to make sure you understand every medication that you're placing in your mouth, what purpose it serves, what you should expect from it, and if you're having any adverse effects, be able to recognize those and feel comfortable about talking to your doctor about it. So we'll start with, first of all, just heart disease in general. And we know that it's the #1 killer of Americans. When we talk about heart disease, we're talking about one person dying from heart disease every 33 seconds. And so for many of us, it looks like, hypertension, heart failure, peripheral artery disease. There are many ways that heart disease can impact the body, but we need to know not only how to treat it, but how to prevent it. We had a conversation earlier that we love the crowd that's here today, but we would encourage you to get your children and your grandchildren in an audience like this, because while we want y'all to continue living healthy, amazing lives, we want those coming behind us to get preventive care so that they can prevent some of these issues and maybe decrease the number of people that's dying from heart disease. When we talk about medication management, of course, me being a pharmacist, it's important that you take your medications properly, but there are 4 key steps to proper medication management. The first is adherence. I can't tell you how many patients I've called in my 20 years of pharmacy who did not pick up their refill on time. Now, I know that's not none of y'all. Everybody here gets their prescription every 30 days, every 90 days. Do I see nods? Who said no? Thank you for being honest in the house of the Lord. Thank you for being honest. I have had to call so many patients whose prescription was due if they were taking it properly, and for some reason, they don't need it now. Oh, I have another 2 weeks left. To me, that means you're not taking it properly. So the reason that bothers us as healthcare professionals, you've done the work. You've taken the time to make your appointment with your healthcare provider. You've gone to the appointment, however long you had to wait in the waiting room. You've seen the doctor. You've gotten diagnosed. You've gotten your prescription. You've taken it to the pharmacy. You've picked it up and paid your good money for it. And then you don't take it. Why? Why? So start thinking about that. Adherence is important because if you've been diagnosed with a health condition, your doctor has prescribed medicine to either help heal that health condition, think of antibiotics, things like that, or help prevent complications from that health condition. Think about diabetes and heart disease. So adherence is very important. And if you're to a point where you're like, I just don't know why I can't take this medication on time, what is stopping me from taking it every day, talk to a pharmacist, talk to someone like me. We have tools that can help you with your medication adherence. It's very, very important. The second element of medication management is monitoring. So once you get that prescription filled, you're taking it, you want to make sure that you're monitoring yourself appropriately. So if you have hypertension, for instance, do you have a blood pressure meter at home? Dr. Jennifer, my business partner, and I say every day, every home needs a blood pressure meter. And at least one person needs to know how to use it correctly. So if you have hypertension, excuse me, if you have hypertension, you're taking blood pressure medicine every day, you don't just need to know your blood pressure when you go to your doctor's office. You need to know it throughout the month. You need to take your blood pressure several times a week so that you know what your kind of normal is, so when something happens and it becomes abnormal, you know that this is not right. So we want you to monitor your health conditions. If you have diabetes, you should be checking your blood sugar, either by using the traditional glucometer where you prick your finger, or wearing something like the continuous glucose monitor, where it's continually monitoring your blood sugar levels. But monitoring is so important because when doctors prescribe medicine for you and we fill the medications, we're trying to prevent the progression of chronic disease. We're trying to prevent complications of chronic disease. And the only way we know we're doing that correctly is by monitoring. You monitor at home, we monitor when you come into the office for lab work. The third thing is communication. I tell people all the time, gone are the days where you go to your doctor's office and smile and nod. How many have done that? Whatever your doctor's saying, you're like, okay, yes, uh-huh, uh-huh, uh-huh. Those days are over. You're at events like this because you want to be educated about health conditions. And because you're being educated, you should be at the center of your healthcare team. So you may have your primary care physician, that's your quarterback. That's the person that's going to tell you the plays and going to kind of make your treatment plan a realization. Then you may have an endocrinologist, a nephrologist, a cardiologist, all of these different doctors. They're all the other people on the team. I'm not a big football fan, so I can't tell you the positions, but just think of everybody else on the field. And so the quarterback is throwing the ball to the cardiologist, and he's managing your heart. And your PCP may throw it to your endocrinologist, and he or she's going to manage your diabetes. But you are at the center. So you expect your doctors to communicate with each other, but you need to be able to communicate between all of these players as well to make sure that the message is being passed. So again, gone are the days where we smile and nod. We're not doing that anymore. We're asking questions. We're asking doctors, what is the plan for me? If I take this medicine every day, what should I expect? And if you can't ask your doctor, ask the nurse, ask the pharmacist, but we need to be asking questions. And the last part is understanding your medications. I've spoken with many, many patients who every week sit there and fill that pill reminder with 10, 15 different medications. And the only way they're able to identify them is by what they look like. I need my green pill. I need my white capsule. Y'all sound like y'all familiar with that. We want you to know the names of your medications, and they are hard to pronounce, but typically if you're talking to a healthcare professional, if you can give us what you think it sounds like, we can kind of fill you in. I can't tell you how many times I've had patients tell me, I need my Metformin. Metformin is not a medication, but metformin is, and I know that, and I know what they're trying to say. So if you can't say the whole word, we're okay with you spelling it. We're okay with you trying to sound it out phonetically. Just find a way to kind of remember what those drug names are, because it's important. If you pass out right here, we'll want to know what medicines you're on, and we need to be able to communicate. You need to be able to communicate that to different people. In addition to communication, if you can't communicate it verbally, we want you to have a list. So everybody needs to have some type of list in your wallet, in your purse, with all of your medications, your known health conditions. Because again, if you're in here and Bishop Hammonds is just slaying the word of God and you pass out, somebody needs to be able to find out what conditions you have so we know what to do. So we have to be able to communicate either verbally or through written notes. And then I was going to go into briefly the medications of heart disease, but there are so many different blood pressure medicines and blood thinners and different things that you can take. I don't think that's appropriate for this setting, but if you'd like to know more, please reach out to us. I think they have our information on the screen. But again, I just want to stress the importance of adherence for medications. If y'all can make a promise to me today that you will take your medications as prescribed, and if you have a problem doing that, that you will reach out to either your pharmacist or your healthcare provider, whether that be a nurse practitioner, a physician assistant, or a physician. Tell somebody that I'm having trouble taking this medication, because if we don't know, we assume that you're taking it every day. So when you come into the office and your blood pressure has spiked, what is the first thing we're going to do? We're going to increase your dose. But if you haven't been taking it and we increase your dose and you go home, you say, I'm going to do right. My doctor had to increase my dose. I'm going to take this new dose. And you take it and your blood pressure plummets because you didn't really need that dose increase. Now we have another problem on our hands. So these are the kind of things that we're trying to educate people in the community, just to make sure you're aware of how the healthcare professionals' minds think. And our goal is to get you to the goal. And that's another thing, remembering what your goals are. So if you have hypertension, how many of you know what your goal blood pressure is? For those of you who have hypertension, I see a few hands. We need everyone in here, if you have a chronic condition, whether it's diabetes, high blood pressure, high cholesterol, we need to know what your goal is. Your doctor should tell you what your goals are. And when they do your lab work, don't accept, oh, your labs were okay. We want to know what the number is. What was my total cholesterol? And what was it compared to last 6 months, to 6 months ago? Is it trending up? Is it trending down? So that way we know if you're making lifestyle changes, if your cholesterol is trending down, we say continue those lifestyle changes, you're doing well. But if your total cholesterol is good, but you're trending up from previous visits, then we need to know that, because we'll need to say, okay, it's okay right now, but if you continue doing what you're doing, it may go up into, a dangerous zone in the future. So it's important to know trends, where your numbers are trending. Many doctors have the electronic health records where you can actually print out your lab work. Take a look at that, and if you don't know how to read it, call us, we'll help you. The other thing is follow-up, and that's the last thing I'll talk about today. Many of you probably see your doctor at least 2 to 4 times a year. Most people see their doctor once every 3 months or so, especially if you have chronic conditions. Make sure that you keep those appointments. They're very important because the doctors need to know that the medications that they're prescribing for you are working. And if they're not, we need to try something else. But the only way we'll know that is if you keep your appointments and you come in and you do the lab work and you go in and see the doctor on a regular basis. So make sure that you're following up with your primary care providers, you're following up with the other doctors on your healthcare team, so we know that the treatments that are being prescribed for you are working properly. And the very last thing I want to do is empower you as the patient. Again, you are the center of your healthcare team. We want you to feel empowered. We want you to feel educated so that you can understand everything that's going on regarding your health. We love, Dr. Jennifer and I love to meet people in the community, and we'll ask questions. When was the last time you took your blood pressure? What was it? Is that at your goal or is it above goal? What was your last A1C? I mean, we quiz them almost like we're teachers or something. But we want people to know it's important to know these things, because the more you know about your health, the better you are to control it, and you can live the long, amazing life that Bishop Hammonds prays for y'all about. So I'll be here to answer questions at the end. I thank you for your attention and have a great afternoon.
Thank you very much, Dr. Long. That was really, really good. But when you talked about someone being the quarterback, you talked about that. I think our next speaker is going to tell us really the more important person is the general manager, the person who really makes sure all the parts are connected and working in order. And that's going to be Dr. Carla Turner. Dr. Turner earned her BSN at Birmingham Southern College and then obtained a Master of Nursing in Adult Health Nursing, followed by a doctorate of nursing practice, both at the University of Alabama, Birmingham. She is an assistant professor at the University of Alabama, Birmingham School of Nursing, is currently part of the University of Alabama, Birmingham Advanced Heart Failure Program. Dr. Turner will discuss cardiovascular patient navigation, navigating care for your unique individual needs. Doctor.
Good morning. Good morning. So before we start talking about navigating as patient care, I kind of want you to think about, can you remember back a long time ago when you were going to try to leave your home and go to a destination that you had never been before? You may pick up the phone and call a friend and say, hey, can you tell me how to get to XYZ? Or you may pull out a map and you start looking and see if you can find your way. Or you may stop on the side of the road and ask someone, how can you get to where you're trying to go? Imagine the advancements that we have today. We can actually get in our car, program an address in, and it'll tell us exactly how to get to where we need to go. Or we can actually tap an app on our phone, program an address in, and it'll tell us exactly how to go. And it'll even let you know when you make the wrong turn as well. So what I'd like to talk about is navigating your health care. I kind of want to pull you into this conversation for just a little bit, just a one word. Can you load my slide, please? Okay. So when you think about your experience in healthcare, you may have been in a hospital, you may have had a doctor's appointment, you may have gone to the clinic. What one word or a few words can you think of to sort of tell us about your experience? And we're Baptists here, so this is not a shy group here. Anyone want to share a couple of words of your experience? Yes.
That I struggle with it. Because I was young, and I didn't want to have a stroke like my brother did at the age of 30 and died. So I remember sitting in the office crying because I had already been through two different types of blood pressure medicine because I was not, as the Dr. Pauline said, I wasn't taking my medication, so I wasn't being honest with my doctor. But when I did finally start taking one that he put me on, I remember telling him that I get these tingles in my fingers and these tingles, in my feet. And he was like, well, I've never heard that before. It was a Caucasian doctor. And I said, well, I must be the first one because I'm telling you, and it makes me dizzy, and it was lisinopril. And so he wasn't listening to me. And so because my blood pressure wasn't being managed, he upped it. So the tingles increased, the dizziness increased. And so he wanted to increase it again. So I fired that doctor. I found me another one.
All righty. Thank you. So what she's pointing out is she didn't feel listened to, okay? The other thing that I hear a lot from patients is, I get lost, I can't find my way. I don't know who to call. I don't know why I'm taking this medications. Next slide, please. So we have done a great deal of work in hospital care to try to make it an easier experience for patients. And so we have what's called patient navigators. Now, that may not be the terminology that's used at the facility where you go. It may be a social worker. It may be a case manager. It may be a care coordinator. But a patient navigator is a person or a team who helps patients, families, and caregivers to overcome barriers to health care, to facilitate timely access to medical care, and overall to improve health outcomes. Next slide, please. So I work in a heart failure clinic. And the clinic that I work in was developed as a part of a grant. And it was developed because what we recognized at UAB is that there were patients being admitted with a diagnosis of heart failure, and they didn't have anywhere to go after they received that diagnosis. So we are what we serve underserved patients. These are patients who don't have insurance. They may have Medicaid, they may have Medicare Part A and not have Part D, which Part D, as you know, gives you access to medications. And that's how we manage heart failure, is through really good medications that help us improve the quality of life for patients. We operate by way of what we call an interprofessional collaborative practice team, because we realize that heart failure is a very complicated clinical syndrome. And so I know you've heard a lot about heart failure, but I just want to tell you a little bit, because I could go on and on talking about heart failure. But heart failure is a clinical syndrome in which the heart may not be able to pump blood enough to meet your body's need. Okay? And when we see that, usually we see what's called a reduction in your ejection fraction. Some of you, if you have a diagnosis or know someone, you may say, well, your heart is functioning at 20%, for example. That means that your left ventricular ejection fraction is less than 50 to 55%, which is a normal range for heart function. For patients who have heart failure preserved ejection fraction, their heart may be pumping well, but it may have difficulty relaxing to fill with blood. We call that diastolic dysfunction, okay? For heart function that is reduced, we call that heart failure reduced ejection fraction. We talked about amyloidosis. The one thing that we have noticed in clinical practice is that our patient may have normal ejection fraction. And so that's the quandary that we're looking at for those patients who have heart failure preserved ejection fraction, that have multiple symptoms, they're in and out of the hospital. We're evaluating those patients for amyloidosis. So we are learning along the process as well. I did review the session from last week, and one of the gentlemen said he was determined to come to UAB. So this is a benefit that he saw. There are 2 scanners in this city that we can actually scan and pick up changes that may be consistent with amyloidosis. And guess what? We have one of them at UAB. And so that was the benefit of navigating his care to come into the right place so that he could actually receive a diagnosis of amyloidosis. We practice by way of interprofessional collaborative practice team. I want to highlight the role of 3 people that's on our team. The first one being a social worker. Now, social workers actually assess living conditions, financial situations. Is there a presence of any psychiatric disorders? I can tell you, patients who are depressed, they're not going to take their medication. Sometimes they don't even want to get out of bed. So we assess for depression and we treat depressions, and then patients' overall compliance with their medications and their program is better. We also have support systems. If you don't have anyone that's going to support you and encourage you, to help you if you need help, then patients usually don't do well. So social services actually help us to acknowledge and identify those situations. We have what's called a social determinants of health coordinator. So what are social determinants of health? We're hearing that a lot. So these are non-medical factors that impact your health and well-being. Number 1, do you have access to care? Number 2, do you have transportation to get to the doctor's office? These are a lot of things. Number 3, now we'll talk about that. Do you have access to food? We have lots of food deserts in Birmingham, whether you realize it or not. We've got a few new supermarkets that have come up, but sometimes people have to travel an extensive distance just to get access to food. And more importantly, do you have access to healthy foods? The third person I want to highlight is our pharmacist. The way that we manage heart failure is with medications. And the Heart Association and the American College of Cardiology has done an extraordinary job in terms of research, in terms of what medications we need to actually have patients on to try to improve their heart function and to improve their quality of life. I call it the Fantastic Four. And whenever I speak about heart failure, I always talk about the Fantastic Four. You may have heard about beta blockers in the past, medicines like metoprolol, carvedilol. You may have heard about medicines like spironolactone. But the medicines that you may not have heard about, that you need to ask your physicians about, if you have heart failure, are you on what's called an ARNI, an angiotensin receptor neprilysin inhibitor called Entresto? If you're not on an SGLT2 agent, Farxiga. You need to ask your physician, why aren't you on Farxiga? These two medications, I can tell you, I have seen remarkable results from those medications. Patients, number one, they'll say, I feel so much better. I'm able to do more without having to sit down and rest. So less shortness of breath, less fatigue. The other thing is, I've seen some wonderful recovery in heart function by using these medications. So if you're not on those medications, I want you to navigate and ask some questions about those medications. Next slide, please. So let's talk about access to care. What's your ability to get healthcare services when needed? What are some of the barriers? The one that I see a lot is insurance. And I want you to know today that you don't always have to have insurance to be able to get the appropriate care. You just have to search your community and begin to ask questions. Where can I go? What we do in our clinic, patients come without insurance, we try to identify what are the opportunities for us to be able to connect them with affordable care, for example. Are they eligible for Medicaid? A lot of patients are eligible for Medicaid and don't even know it and have never applied for it. Cost of care. Can I pay for it? A lot of times patients are concerned. They don't go when they have a symptom because they're concerned about large bills that they cannot cover. Transportation. Do you actually have a way to get to your clinic appointments? Do you have a way to get to the emergency department if you're having symptoms? And then what's the wait time? You go to the emergency department, 4 hours have gone by, you gotta pick your kids up from school, you gotta be at work. You know, that's the challenge that lies before some patients that sacrifices their health from going to having access to medical care. Knowledge of cardiovascular diagnosis. You know, what does it mean to say that you have high blood pressure? What does it mean when you have heart failure? What does all of that mean? Next slide, please. So let's talk about your role. This is a favorite part I like to have conversations with my patients about. Understanding your diagnosis, heart failure, hypertension, coronary artery disease. You've had a heart attack. What does that mean? What does it mean if I have high cholesterol? What can be the complications of that? Ask questions and talk to your healthcare provider. As was mentioned at last week's session, if you're sitting across from someone who's not listening to you, who's not answering your questions, then you probably need to be sitting across from someone else. And you have that right. So ask questions. And the thing that I always tell my patients to do, write your questions down before you come to see me. Because a lot of times, by the time you get there, just the stress of getting there, you forget, you know, one major question that you had. So write your questions down. What are your treatment options? If you're prescribed medications, what are these medications? What do they do? Now, I know they have complicated names, so you don't have to be able to necessarily give the complete name, but just try to sound it out a little bit. We're okay with that. We can figure out the rest of it. Would exercise benefit you? Also, if you have to have a surgical procedure, how long is it going to take me to recover? How long will I be out of work before I can get back to work? So asking these important questions will help you make your decision. Also participating in your decision making. I have to actually bargain with my patients all the time about medications. I have patients that say, look, I'm not taking medicines 3 times a day. I, as a provider, I have to respect that, and I have to generate for them a medication plan in which they're going to be able to do. So it's going to be useless if I prescribe a medication and they're not going to take it. So we bargain a lot in terms of what's going to be the medication plan. Managing lifestyle factors, dietary changes, that's a tough one. We're here in the South, in the Southeast, we're in what we call the heart of heart failure and stroke. We call it the heart failure and stroke belt. So we've got to do better in terms of what we're eating and how we're eating it. Yeah, if you eat vegetables and you're cooking them with pigtails and smoked meat, that's not really the best option. And that's what we do. So we need to rethink what we're doing and how we're cooking food. We got to cut down on the salt. Sodium is also termed one of the killers, one of the white killers of African Americans. And we shake salt. Sometimes when I'm sitting in a restaurant and I'll see someone get their food, they'll just pick up and start shaking salt. I was like, they hadn't even tasted it. So we've got to decrease the amount of sodium intake. We have to decrease the amount of sugar. That's leading to obesity and that's leading to diabetes. Decrease alcohol. Now, I went to a conference recently and this is what they said. 1 alcoholic drink for women per day and 2 for men. Now, you don't have to do it every day. If you want a glass of wine, red wine would be a choice. So mind the amount of alcohol you are consuming. And I always tell my patients, exercise. If I can put exercise in a pill and someone can swallow it, the whole world would be healthy, okay? So we got to exercise. When we talk about exercise, it's not preparing for a marathon, okay? I'm just talking 30 minutes per day of exercise. So what's my role as a patient navigator? I sit down and I educate patients. I talk to them, I talk to their family. I coordinate their care. I address the barriers for them. In our program, a big part of what I do is medications. We have something called Dispensary of Hope, which is a charitable program that we pay into every year. And we can provide patients medications for free. And these are the medications that I use to treat heart failure. A lot of you that may not know about, have ever heard about patient-assisted care programs. Pharmaceutical companies have programs in which you can complete an application for a medication that you can't afford. They will evaluate it, and you can likely get that medication for free, and they will ship it to your home. If you have a high copay cost, they have something what's called copay cards, whereas it may take your copayment from $20 possibly to $10 and possibly to $0. So ask about copayment cards. Also 30-day free medications. When I start medication on a patient that I know that they can't afford and I've applied for the patient-assisted care program, I use a 30-day free card so I can go ahead and start that patient on that medication. So the overall goal for me is to improve heart function, to improve the quality of life, and to improve longevity. And the reason why UAB hired me is, number one, to keep patients out of the emergency department and to keep patients out of the hospital. Thank you all very much.
Thank you very, very much, Dr. Turner. That was some good advice that you gave in to us. Yeah, I think it's interesting because our next speaker is going to address a couple of the social determinants of health that you mentioned. So very important for us to be aware of. Dr. Laurel Wilkinson is our next speaker. He's a graduate with a BS in Biological Sciences from Tennessee State University. Where's my Alabama A&M person out there? I know you're out there somewhere. Where are you, my sister? A couple of, well, you know. When you're from the Mecca, when you're from the Mecca. But it's always good to be in the company of my fellow HBCUs. But there is how. Anyway, after obtaining his BS degree, Dr. Wilkinson then attended University of South Carolina, where he earned both his master's and public health and PhD degree there in health sciences policy management. Dr. Wilkinson is an associate professor of community health and human services at the University of Alabama at Birmingham and has an appointment with the School of Medicine and the Minority Health and Research Center. Of particular note, Dr. Wilkinson is the principal investigator of Gear Up Alabama, a program to increase the number of low-income students who are prepared to enter and succeed in post-secondary education. And Dr. Wilkinson, you will notice, I always make make it a point of including the educational background of everyone that comes up here, because I don't know about you, but everybody's mamas and papas are very proud of us and the degrees that we've had. And you know, it's particularly important in this day and age with what they're trying to take away from us as black folks, to know how good we are in the classroom. DEI or no DEI, we are some smart people. And I think it's necessary that we pay homage to that. So keep going with what you're doing. Dr. Wilkinson also started the Wilkinson Wellness Lab to encourage individual, families, groups, and communities to adopt healthier lifestyles for optimal living. Today, Dr. Wilkinson, who could speak to us on many different subjects, as you can see, will speak to us about nutrition and psychosocial support for a healthy heart. Dr. Wilkinson.
I think it's still morning. Good morning. It's great to be with you today. I want to thank members of the church, Pastor, Hill Collaborative, and all you good folks, family, for being here with us today. It is truly a great day to be in the house of the Lord. We're here to talk about heart. And my slide's not up there yet. There we go. Talk about heart matters. I had the privilege of using grant money from UAB to pilot two studies related to the heart of men, African American men in particular. And my talk this morning is going to talk about healthy eating. Let's say healthy eating. Healthy activity, healthy rest, together, it matters. All right, next slide, please. So we're here and we're talking about the heart, and I know that y'all have had several talks now, so I'm gonna move ahead, but what I will say is, as y'all may know, heart disease is a listing of several different conditions. It's very highly prevalent in the United States, certainly here in Alabama as well. And I think, we tend to think about heart disease in a way where, it just kind of sneaks up on us sometimes. We may feel a little chest pain, or we may characterize it as a little heartburn, but we shouldn't take those characterizations lightly. I've had the chance to listen to a few of you as you were walking in. You've shared testimonies, the power of testimony, come on. You've shared testimonies already, and we should not take this lightly. We should listen to the wisdom of our brothers and sisters. When we think about the extreme fatigue, the good doctor was up here talking about walking, there he is over there, walking to the driveway and feeling a little sense of fatigue. We should not take that lightly. If we feel dizziness or shortness of breath, we should not take that lightly. If we feel a little bit of palpitations in our chest, we should not take it lightly. Because all of this could be the signs and symptoms leading to something worse. But if we catch it early, as some of our good friends have said already, then we can do something about it. And that's why we're here today. Next slide, please. So my background is public health, and so in public health we talk about risk, and so it just so happens that I have some statistics here, but I want to make it just a little bit more present, if I might, as we are comparing ourselves to others who are in society. We'll call them European Americans, or we call them white. That's how it is in public health. We look at a referent group, the predominant group in society, and then we compare other groups to that more, I should say, prevalent group. There's more European Americans in Alabama. There's European Americans in the United States. So you kind of catch my drift. It doesn't make anybody better or worse. It just means that there's just more of it, okay? So 20%, we are 20% more likely to have been diagnosed. Can I move this? Yes, I can. There we go. Have been diagnosed with high blood pressure. Now, I counted the chairs, if my math is correct, and there are, in this center section, 5 chairs. So if we're talking about white European Americans, it's 1, 2, 3, 4, 5. They got hypertension. But if we're talking about us, I got to add this extra chair right here. Our risk is greater, okay, for hypertension here. But when we talk about controlling our hypertension, I got these 5 chairs in the center right here, 5, 20, 40, 60, 80, 100%. But when we're talking about controlling hypertension, for my white brothers and sisters, they're doing a good job. For us, I got to remove a chair. Because we're 20% less likely to control our hypertension, y'all. We got to do better. We got to do better. My women in the house, you are 50% more likely to have hypertension, high blood pressure, compared to our white brothers and sisters. So 1, 2, 3, 4, 5. I take that chair and I add another chair and a half of another chair, and that's my risk for my women. I'm not here to pick. I'm not here to cause offense. I'm here to acknowledge and say, let's work to do better. So in Alabama, I looked up, I had to run some calculations. I tend to play with the computer a little bit. 48% of my brothers and sisters, Black African American, in Alabama are living with high blood pressure. 35% of us are living with high cholesterol. 19% of us, 20% of us, and I think this is a low number, are living with diabetes. And I will tell you, full disclosure, I have been diagnosed with prediabetes since the age of 27. I fight it every day so that I do not become diabetic or that I delay the onset of diabetes. So what do we need to do? Next slide, please. Well, first, we got to understand our risk. So when we're talking about heart disease and risk factors, we got to understand high blood pressure leads to heart disease, high cholesterol, smoking, diabetes, obesity, eating a diet high in saturated fats, not getting enough physical activity. These are all things that Mrs. Turner just got through saying. Tobacco use. We may be at more risk because of who we are and our family history. But then there are also other risks that have been determined not by us, but by society. And we got to be clear about that. Because what I'm going to call you to do later is to advocate not just for your individual health by working out, exercising, doing the things that you need to do, but we also have to work to change our community. We also have to work to change our environment. We also have to work to change how we come up and develop. We got to change education. I've talked to a number of schools in the area, and we're not doing as great a job with health education. As a matter of fact, they took certified health educators out of the school systems. How many of y'all grew up and you had a health teacher? See? But the generations after you do not have a certified health teacher in school. We could talk about income and we can talk about poverty as well. And again, I'm not here to offend. I just, we should work to get, better incomes. But that also means we have to make changes in society. We want to be employed. That's good. We also want jobs, fair paying jobs in our communities. We want to make sure that our neighborhoods are safe to run and play and have activity so that we can get out there and walk. I'm going to encourage us to do that later, and that means making changes to the built environment. And we want to make sure that, we're in a church right now. Central place for how we connect to one another. I've been doing this, thinking about this the whole day. I'm like, I wonder how many laps if I went around this congregation would be a mile. Because I'm that person at UAB. If you were to come to my office, you would see me walking with some weights, and the students just be like, "What's his deal?" But I got some weights in my hands. I put some tennis shoes on, and I'm shirt and tie, and I'm huffing it up and down my building, up and down the stairs, because I got to make sure I get that physical activity in. So we also got to change our thought processes. Next slide, please. So when we think about healthy eating, then let's talk about how we balance the calories. Because if we think about the calories as they're coming in, like, I don't know how many calories are in a Big Mac. Just gonna keep it real. Or too many, and a fry, and a Coke. But if I want to be cognizant of that and be aware of it, then I can. We got these magical devices, I think they call them mobile phones. And you can get an app and it can track your calorie intake. And then you can say, you know what, to work off these calories, I gotta do some 20 laps around this congregation. Right? Around the church. We got to think about how we get a variety of fruits and vegetables in. I was looking at my GPS as I was sitting there, and I know that Carver Jones Market is not too far from here. I think it's about 5 miles from here. Black-owned, Black-operated market that's selling fruits and vegetables. I know they're selling fruits and vegetables because CJ Market turned Fairfield from a food desert to a place where we now have fresh fruits and vegetables. Can we talk about that? And Mr. James Harris, thank you. Mr. James Harris is doing a great job over there. And I just want to encourage all of us. I'm going to leave and go over there right now. I want to encourage all of us to support. Because he's really doing something special. He's a dear friend of mine. We got to choose whole grains. That helps to get stuff out of your system. I'll just keep it at that. Okay? Helps to flush out the system, get the cholesterol out as well, lower the bad cholesterol, help you increase the good cholesterol. We need to use non-tropical liquid oils. That just means use the good oils, because the bad ones are full of saturated fat. And these are things that you can go to a website and you can find. You can Google it. Just make sure we're using valid sources like the CDC or the American Heart Association. I don't want to just spend too much time, because I really just want to boil it down to, when I was health coaching, I would just tell my guys, eat fruits and vegetables. Make sure that they ain't not canned and filled with salt. Let's use the fresh ones to the best of our ability. Even the frozen ones that you put in the microwave, they don't have no salt added. We're still good. I would just tell them, eat fruits. You can eat fruits and vegetables all day. Actually, you can eat 2 servings of fruits, especially those who are pre-diabetic or diabetic, and then 3 or more vegetables each and every day. You want 5 or more vegetables. You want 7 to 9 plus vegetables and fruits every single day. That's what we want. 5 or more, that's a minimal standard. You can eat fruits and vegetables all day. Let's next slide, because I know I'm going to run out of time. Healthy activity. Like I said earlier, I was thinking, I don't know how many. Sometimes we don't have safe places to just be active. I'm just going to keep it real. I live in Shelby County. My parents call me up still. I'm a 46-year-old dude. Come on now. They call me up and be like, hey, don't be running out there in the dark. I know you got to run. I ain't going to tell you don't run. We know you're going to run. Maybe you should wake up early in the morning. I don't like waking up early in the morning. I like running in the evening time. Ahmaud Arbery, he went out for a run. We got to keep it real. It doesn't have to be people against us, though, that don't look like us. We got people who look like us who are against us, too. And we got to be real about that. And that's why a church can be a safe place for us to do like we just did with Dr. Richardson here, and do some sit and be fit. And then we can do some incline push-ups for those of us who can. I'm just thinking about everybody. But we got to think about how we can get our resistance training on. I don't know how many laps this would take me to do a few miles, but I can tell you I've done phone conferencing in my house, and my longest walkway is no longer than to half of that door, and I just walked in place for over an hour. If that's what I got to do, then that's what I got to do. And we got to do that because we need 150 minutes of aerobic activity and walking. For those, if walking means doing this, then that's good. But if you're able, let's work up to this. Because that's how you get the heart rate up when we walk. And look, we can use some light weights. This microphone is about a pound. You can do this. That's what I do each and every day. And this is how we strengthen our muscles. This is how we can avoid injury. This is how we can strengthen our heart to the best of our ability, whatever our ability is. That's what we need to do. And that's what I would coach my men to do as well. Next slide, please. Healthy rest. Like the word doesn't talk to us about getting some rest now. Come on. So I was a guy, and I'm still a guy, but I was a guy who would be like, gotta be careful. I'll be that type of guy who'd be like, man, I just worked a double-double, you know what I'm saying? I don't need no sleep, I got maybe 2 hours last night. I'm good. What you need me to do? I could do this all day, right? And I used to brag and boast about it. I'm serious. I know some of y'all like, I do that too. And then I had to go to Kirkland Clinic because one day I did exactly that, and I had a physical, a checkup right after it, and stayed up to about 4 a.m. working on a grant. Had to get it in, but my checkup was like at 9 a.m, and so I got 3 hours of sleep. Went to the checkup and got a irregular EKG. They tested on 2 different machines because they're like, you look good, but you got 2 irregulars, we're going to get you into an ECG. At Kirkland, did that. It came back normal, thank God. Then I went to the doctor and I said, I probably should have told you. I did some research. I probably should have told you I only got 3 hours sleep last night. She was like, yeah, we probably would have just done another EKG. We wouldn't have sent you to get an ECG at Kirkland. My point is, that was just one day. What do you think doing that over the course of time will do? Raise your blood pressure, make your heart work harder. Your body's not getting time to recuperate, where it regenerates cells at night. Your brain activity is just constantly going, putting you at risk for Alzheimer's disease, dementia, high blood pressure, sugar levels don't come down because you ain't got enough sleep. Hormone imbalances, mood imbalances, anxiety, depression, weight gain, because your body, again, is not resting. And so we got to look at the benefits of what good rest will do and not just think about how society thinks that we got to go all the time. Because what society is trying to pressure us to do, and again, I'm not making them the big bad enemy, but what I am saying is they ain't looking out for your best interest. You got to look out for your best interest. And that means taking a pause, getting some rest, taking naps if you need, getting some good sleep. And I know that's hard. I got a 12-year-old, a 9-year-old, and an 8-year-old. And they tend not to think that I need sleep. Let me get ready to go with this. Next slide, please. So I call these the core 4: healthy eating, healthy activity, healthy rest, sleep, but also stress management. Because if we let society stress us out, then excessive stress will kill us. And I'm just keeping it very real. So we got to get rid of the chronic stressors because they're linked to mental health, but they're also linked to our heart health. And it's going to cause irritability. When people say they got a bad attitude, they may not be getting enough sleep, and they may not have some troubles managing their stress. Or when we think about disruptions, the headaches that come. Listen, I think that I don't have to tell y'all, but I'm going to say it anyway. Let's pray about what's stressing us. Let's pray for the wisdom to change the things we can change, but to let some things go sometimes, and the wisdom to know the difference, right? Let's talk about setting a regular bedtime, or having a wake-up routine that's regular, or getting the exercise that we need because it can help us go to sleep at night. Let's think about how we talk about meditating on the word. We can talk about meditating on things that are going on in life. We can talk about how we can focus ourselves to deal with the problems that we have. Let's address things head on. Sometimes we like to sweep a little problem under the rug. All that does is just make your house much more dusty. We got to solve, the problem ain't going away. So if we address it head on, then we can make it go bye-bye. And then we'll experience less stress. And I'll end with this. Next slide, please. We got to change some of these patterns that we see within our people. These are African-American people. They're Alabamians. This is according to national data that was almost taken away from us. Let me be clear, because the new administration said, let's take this data away, so I wouldn't be able to even present this to you, except that I had some old data available from these data sets that I saved so that I could share with you what the real is. And these numbers ain't bad, okay? Exercise. About 30% of us aren't exercising in the last 30 days. We can improve that, okay? We can encourage our brothers and sisters to exercise. When it comes to eating at least one vegetable serving a day, that's the kind of brownish bar. It looks a little bit differently. So that's going to be the orangish bar, is fruit a day. So 45% of us are not eating at least one fruit a day. We got to change that. Green, at least one vegetable serving. 31% of us aren't getting a vegetable serving. We got to change that. I already told you, we want more than one. We want like greater than 5, right? And then getting enough sleep at night, 7 to 9 hours hourly, that's 43% of us are not getting the sleep that we need. We can change those behaviors by ourselves. We could do that by ourselves, for ourselves. And the last slide, please. And here's how we can encourage, we need more of these type of workshops, because it needs to be top of mind. It needs to be top of mind. Look, if we don't have health, then it means we ain't here. And as long as we're here, we got work to do. We got a purpose to do. He's enabled us to do his purpose, but we got to be healthy to do it. So we got to encourage one another. As iron sharpens iron, one person sharpens another. So we know the verses. We got to do more of this. If someone needs a ride to a store so they can get some healthy food, then we need to take them because they're in our flock. So these are just some examples of things that we can do for ourselves to support one another towards a healthier and more well existence. So I'm with you. I don't know. I think I'm going to be here. I'll share my information. You'll probably get access to the slides, but if you need my email, my phone number, or anything like that, I'll get it to you. Thank you for your time and energy this afternoon.
If you would demonstrate the HBCU walk one more time for us, Doc. Come on, let's see that HBCU walk, man. All right. Thank you very much. I want to remind you that at the conclusion of our last speaker, we're going to do a Q&A session after that. So I hope that you've been writing down potential questions or comments or things you may want to know a little bit more about, and we'll collect those and try to answer a lot of that for us at the end. Our next speaker is Ms. Kathy Cartagena. Boy, I hope I didn't. Did I get it? All right, I tried. I was practicing too. I apologize. She obtained her BS in Health Sciences and Allied Health from Ramirez College in Puerto Rico. She is currently a Program Manager 2 for the All of Us Research Program at the University of Alabama, Birmingham. This program's goal is to help researchers understand why people get sick and how they stay healthy. Today, Ms. Cartagena will speak to us on addressing health-related social needs. Please, if you would.
You're fine. That's why everyone call me Cece. So it's not you, it's overall. So it's a good time this morning to start opening our ears because you can tell I'm not from here. That means my accent will be stronger. So, but feel free to raise your hands or either talk or ask if you don't understand what I'm trying to say. I will try to do my best, okay? Thank you to the pastor because this morning you remind me a lot of manners that we had in Puerto Rico. Our church, actually, my church in Puerto Rico is similar to this one, and I feel in home. So that was something that I started feeling very well this morning when I was coming this morning and say, well, I'm going to be talking to a community that I've never been talking before, so let's see how it is. So here I am, I'm Kathy Cartagena. It sounds like henna, like the hen, but everyone's called me Sissy, even my boss, even Dr. Fuad called me Sissy, because she said, Kathy, it's too hard for me. So, but I'm working on the All of Us research program, but also I work for the Minority Health and Equity Center at UAB with the SEAL program, and also with the Live Health Smart program. That's two programs that we are now working very intense through the community health workers. And what I'm going to be talking this morning is how the community health workers are impacting our communities here in Birmingham. A question this morning based on what is breaking our community in terms on our heart and our health. So anyone know what is impacting or breaking our communities? Some of the topics are the healthcare access. So not everyone is having that access to the healthcare system, the economy, also the food insecurity, the environmental, the mental health challenge, and the systematic inequities. And we know as a minority, and I include myself because I'm another minority, is some system here in Alabama, including Alabama and Birmingham, create some challenge for us to navigate on the health care system. So a community health worker is a new program that we are trying to implement across the whole state, but we are doing our pilot this year here in Birmingham and also Selma, Alabama. So we are about to launch this month in March. And we're going to be starting having coaches that will be from the community. That's the difference that we are trying to, because we have in the health system, we have patient navigators, we have social workers, we have all kind of titles who help the patient. But one thing is when we are working in a huge institution like UAB, that we are pretty much another town as employees, that everyone is coming from different places. But when you had a community member who we train on healthcare access and social determinants of health that is from that community, that he work in the community, live in the community, or either worship in the community, is a person who will be helping this community to understand and address the issues that we're having as a community, and then we can go to the health system and get a better outcome. So that is our purpose, and what I'm trying to do in here this morning is to encourage this community as a church also, that I start thinking what we can do as a community also to be part of this new initiative that is taking part with UAB and some other partnership, that including the YMCA and others, Birmingham, others institutions that will be helping the community to get better access to the healthcare system. So also, I want to encourage everyone to, and this is something that when the pastor was talking this morning about faith without work is death, it reminded me of the book of the Daniel plan, that he talked about how us as a church member, and it's a part on that book that I always remember because I was reading, and I said, it's so true. He was talking about how we come every Sunday when the pastor asks for those people who are asking for prayers. And we are coming every Sunday and ask for the same prayer. Take care of my diabetes, or take care of my heart condition, or take care, but which is the part that us as a community members are doing to take part on the work action. So because we had the faith to come every Sunday here to be asking for that prayer, and we know God has the control, but which is the part that we're doing to take action of self-care? They take care of us. They said, okay, as a minority, and I'm pretty sure that we are very similar, the Latino and the Black community, we take care of everyone. That is our nature. As a mama, I take care of my neighbors, my grandma, my son, my kids, everyone. But most of the time as a woman, we don't take care of ourselves. So I start teaching my kids, I say, you cannot love anyone if you don't love yourself. So it's very important to us to start making that change, because Alabama is now my home after 18 years, and everyone that always asking, are you planning to move? No, because now I have a multiracial family. I have families I have a daughter-in-law who is from the Black community. We have another Black community member in the family who we adopt also, and we also has a white daughter-in-law. So my multiracial family, and I live in Pelham, Alabama. So you can imagine when all of us come and start talking in all the accent. My white daughter-in-law is from Walker County. So you can imagine the accent. The other one is from some area in the south, close to Dothan, that I cannot even pronounce well the town. And when we are talking and celebrating holidays, everyone say, how you understand each other? And this is my answer for everyone. It's just love. It's just love, because a lot of time I have to ask my son and say, what she's trying to tell me, I don't get it. Or when she's doing a joke, and I say, it's a joke for her, but it's not for me. So, but the love, and when we think about how the Bible also talk about love go with everything. And that is including the health. So we need to start loving us, because God is asking also for us to take care of ourselves. We are a temple, His temple. In order to be healthier and align what the God is saying to us, we need to get in that phase, okay? So it's very important. So I encourage everyone, I think everyone received the, we had and I'm sorry, that's my monitor. I have one. So we spread some information about the mobile clinic that we have. Live Health Smart has now including some other areas in Birmingham to bring mobile clinics and also mobile market with fresh vegetables, fresh fruit, and some other food people get access to in a better way. So we are submitting that flyers in here, and we also going to be outside talking about for sale. If anyone want to listen more or learn more about how they get involved as a coaches or community health worker, I'm going to be outside waiting. Thank you, everyone. And I hope it wasn't that hard to understand.
Thank you very much, Ms. Cartagena.
Perfect. Wow, perfect.
Well, you know, it's laziness and ignorance on my part not to get the name right. So we all have, what do we have in our lives? We have our good names. And I think it's important that we all pay attention. Let's bring our speakers up here for us, please. Dr. Flano, Dr. Long, Dr. Turner, Dr. Wilkinson, Dr. Richardson. Please come on back up here. Yeah, sit anywhere you want to. Let's pull this around here, Dr. Boss. Just make sure everybody. Oops, sorry. He broke it. He broke it. If you have a question or you've raised a question, please bring it up. But let me start off first. I want shameless plug, but also want to get some information. So, Dr. Richardson, we want to go to you. How do we get to you and about this information that you gave us? How do we get there? Oh, hold on. Before we go any further, the voice from above, you know, we may think it's God, but it's probably the next person, is Ms. Vini. Ms. Vini has been the audio tech. Give her a hand for everything. Thank you very much. She scares me like God, I'm going to tell you that right now. But nonetheless, there she is. But thank you, Ms. Vini. Thank you for everything you've done as far as getting the slides and keeping us straight. Yes, Ms. Richardson, please.
Yes, I left a handful of cards up there in the front area. The clinic that I work at is M3 Performance and Physical Therapy. You can find us. Our website is M3 Endeavors, so M3ENDEAVORS.com.
Okay, Dr. Long, we have, I'm going to ask, we have a question too for you, but how do we reach you also?
Yes, so I am founder of Meds Plus Consulting along with Dr. Jennifer, who's in the back. We can be reached at Meds Plus Consulting, and that's Meds, MEDS+. So it's Meds Plus all of the other services that we offer. Consulting.com, and we also have a card and a flyer in your folders. So our phone number, website, and everything is on that.
All right, so let's begin with the questions. This is one's going to go for Dr. Richardson, Dr. Wilkinson, if you would. I've heard, tell me if I'm wrong, that during the middle of the day, a lot of us want to get up and we go get that cup of coffee. You know, we're driving long distances, we go get a cup of coffee, thinking it's going to keep us awake. Isn't a little bit of exercise perhaps even better stimulant to keep us going during midday to give us that little perk?
Definitely. I will say I am a victim of getting that midday coffee. But I walking around all day, so it kind of balances out. But yes, exercise is really good. Of course, getting your heart rate up, so that's going to pump blood through the body to your muscles and your brain. That's going to keep you awake.
I'm scared to death to call Dr. Wilkinson. He's talking for an hour. Can you imagine that?
I'll be simple.
Okay.
I'll be quick.
So what do you think about that? I mean, you're a guy who's, in the course of your work day,
Yep.
How do you tell us about that? Is that a good pick-me-up for you also?
It is. Physical activity is great. I'll get up and I'll do a few laps around my office complex inside. And I also will go greet people. Like, I think we forgot how to greet people. But if we just, I'll go and knock on someone's office and have a little brief conversation. It's a great pick-me-up. I'll also go get some water. So those are some great tips to get your energy up during the middle of the day.
All right, Dr. Long, one of the things that when you're talking about pharmacy, particularly some of us who are up in age, and I'm 71, so I'm way up there in age, all right? But I still got my HBCU walk going on. Now, having said that, one of the things that we all notice is that as we get older, it seems like everybody wants to pile on pills. If we could just lift up the pill boxes all day long, that'd be a great exercise alone. But tell me about this concept of polypharmacy and how because you mentioned about this quarterback thing. We're not talking to one another as physicians. So tell me, what is polypharmacy and what are some of the dangers we have to watch out for with that?
Yeah, so thanks for the question. Polypharmacy actually kind of means two things to me. So one is you're just taking a lot of medications, and we call it the prescribing cascade. So you go to the doctor for your shoulder, they give you an anti-inflammatory, but then you start taking that and your stomach starts hurting. So maybe they give you an acid reducer for that. And then you're taking that and maybe your bones get weak. So then so it's a prescribing cascade. Before you know it, and I brought one of our blister packs, you're on something that looks like this, and you're taking 10 to 15 medicines a day, and some of the medicines you're taking is because of side effects from the original medications. So that has happened. It happens, unfortunately, more often than not, especially when people use when they see many different providers and they use several different pharmacies. And so what we recommend is to, number one, make sure that you use one pharmacy if you can. I know there are insurance limitations and things like that, but use one pharmacy that knows that you see several different doctors, because that pharmacist will be able to look at your complete profile and look for things like therapeutic duplications, especially if you're going in and out of the hospital or you're seeing an endocrinologist and your primary care provider. Are both of them prescribing diabetes medicines for you? Do they know about it? Those are things that the pharmacist can catch. Then we also look for drug interactions. There are many, many, many drug interactions. Some are severe, some are, we just watch and kind of see what happens. But when you have a primary pharmacist that knows about you, your health conditions, and your medications, we can look out for those kind of things. So polypharmacy is real. The last stat I read was somewhere in excess of $400 million a year. It costs the healthcare system to manage drug errors. That's a lot of money. A lot of people are being hospitalized because of drug errors, and it's because they are seeing a lot of different doctors. They get stuff through mail order and through their local pharmacy and something over at this independent pharmacy, and it just creates issues. So definitely want to try to get it down to one pharmacy, preferably somebody that you know and trust.
All right. Now, many of the people here said, I don't want to get into this thing of having to take a lot of medications. So what are the things we can do in our, and I'm starting with Dr. Wilkinson first, then coming down. I'm in my 40s. What can I do now, and when do you start trying to eat right? And also, since you mentioned Fairfield Market, I guess you get a cut for every person that comes through there. So where is Fairfield Market located?
Now, that's a good question. I
hope you don't mean where it's located.
No, I think someone mentioned that we have this thing called GPS that gets us to places.
Sorry.
I GPS it, to be quite honest. I don't know the address, but I think the website, is cjmarket.com or something related to that, but it's Carver Jones Market. If you look up Carver Jones Market, you will get the address. And
Gary Avenue.
Gary Avenue?
Gary Avenue.
That's right. So thank you for that. And then in terms of, I think, you asked when do we start trying to work to be healthier, I guess is kind of how I summarize the question. When we're born. I mean, we want our parents to nurture our kids in the way that they should go, train them in the way they should go, and that includes eating healthy. And then as they get older, they will do the same, and they will do the same, and we will see increases in health and well-being. But, I'm 46, and I'm someone who had a journey as well, who was eating whatever was put in front of him because he was trying to just be a poor graduate student, just trying to make it. And that's what I was. But when I had to take my health seriously, I had to do the following: increase fruits and vegetable intake, got sodas out of the house. I got married and my wife took sodas out the house. That's like the first thing she did. Like, I came home from work one day and there were no more sodas. And then I had to, do the same thing: walking, running, jogging, working out, starting to lift weights, stretching, as we did earlier, and just doing the things that, the doctors and public health has informed us to do. Those are the answers.
So I'm glad you only lost sodas. I can't tell you all the things my wife took away from me.
That was the start.
I didn't even notice until it was too late. Now, having said that, Dr. Turner, how do you know you're having a heart attack? Is it possible to have one and you not even know it?
So the common symptoms of a heart attack generally can be chest pain, chest tightness or pressure. It can sit in the middle of the chest. It can be on the left side of the chest. It can be on the right side of the chest. It can radiate, go down your arm, go up into your throat, go between your shoulder blades. The interesting thing, though, is that the symptoms for women are very different. Some of the symptoms that I've seen for women experiencing a heart attack, they thought they were having a toothache. They thought they were having a headache, a migraine headache. So what are some of the precursors for women that I'd like to emphasize that may indicate that you're at risk for having a heart attack? Two things: fatigue. You were once able to walk down to the mailbox, now you can't do it any longer, okay? The other thing is extremely short of breath with very limited activity. So that's basically it. A lot of times, one question I ask is, when you have this chest pain, do you break out into a cold sweat? And usually that's also an indicator. But yes, some patients have had a heart attack and didn't really know that they've had a heart attack, especially patients who have diabetes, because the nerves that transmit pain for patients with diabetes have been damaged. So oftentimes, yes, that can happen.
You all tell me, whoever wants to address this, but one of the things we talked about last week was differences in making a diagnosis of a heart attack based upon a person's race and, of course, gender on arriving in the emergency room. Somehow or another, African Americans to get diagnosed, same symptoms, at a lower rate for having a heart attack compared to someone white. Woman, lower rate than for men. So who would like to tackle this and tell me, are there differences in the presentation between the genders, or is it all the same and it's just the providers who are making the mistake?
There are differences. Oftentimes, when a female complains of chest pain, they'll think that it's an emotional part. She's anxious. She's a hypochondriac. So oftentimes, the symptoms are not taken seriously for women as maybe for men. There's also a discrepancy in terms of African Americans. When African Americans sometimes come in with chest pain, they'll say they're drug seeking. So there are differences in terms of patients being diagnosed accurately and in an amount of time that we can actually help that patient.
So can I fire my provider? That was something, you mentioned something about I have a disagreement with the provider. So I want you, Ms. Cartina, to come along and tell me, can I fire the provider and go get somebody else?
Yes, you can. Now, the thing that you have to take into consideration is what your insurance dictates. You do have a list of physicians or providers that are on that list.
Ms. Cartagena, tell me, is it difficult for us to say that I am not happy with what this, as we heard earlier from the testimony, they weren't meeting their needs. Right. And so how hard is that for us? And do we have that right to go in and tell them, I no longer want you to take care of me?
It is hard to say it, but it's your right to say it. Right. So, and that is the most important that we have to do as a health providers and also community health worker is first is to encourage everyone in the community their rights as a patient, because a lot of us, including minorities, we always are afraid to say something because also we have the other stigma that people are treating us because our race. So, but it's your right. So everyone, every single person who go to the healthcare, they have a right, and we are encourage everyone outside in the community to do their rights.
Okay. Dr. Flano, you showed us a couple of interesting x-rays that, as far as I was concerned, looked like we're having a hurricane developing over the Gulf of Mexico or America, depending upon wherever you want to put it now, and it's slowly coming in toward my heart, which I think we still call the heart. Having said that, how hard is it really to tell the difference between someone with a nodules in their lungs versus someone that may actually have a cancer and or even amyloidosis?
It's really difficult because if you think about the lung, just give you guys a quick, the edge of the lung has a lot of nerve fibers on it, right? If you ever someone bruise a rib or they bruise their lung, it hurts, right? A lot of nerve fibers there. The other part that has a lot of nerve fibers are your airways, right? So you get a tickle in your throat, you're coughing, whatever else. Those you can feel, right? So you know that something's going on if those are affected. But the tissue of the lung doesn't have many nerve fibers at all. So a lot of these diseases can go undetected by knowing that there's something specifically in that area. And that's where either the nodules or other diseases, amyloidosis, can form, is in that tissue area. So it gets a head start. It gets ahead of you.
Now, Dr. Fano, we heard a lot about the importance of going out and exercising. We also heard the importance of us getting better nutrition. Some of us like to garden at home, and so therefore we have our food growing in the dirt, and we get the water from our local water supplies. And we say, okay, we're going to go out running, and I'm going to run, and I'm going to breathe in all this wonderful air. But would you tell me the impact of environmental pollutants? In particular, remind me, when we were here last year, I think Dr. Hammonds mentioned a very startling thing to us about where this church is actually located and how that may impact us.
Yes, I remember that because we were talking about lung cancer at that time, and it was brought up that there were several members in this parish that had suffered from different types of cancer, especially lung cancer, only to find out that there's an old mine that it's built on top of. And a lot of these play a big role in what's in the environment and then how it impacts our health. For example, for lung cancer, we know radon is the #2 cause. It comes out of the soil, especially where mines were. It's radioactive. You can't see it, can't smell it, can't taste it. But it develops in it. And we know these areas of the city, of the towns that have the higher pollutants. Who lives there? We do. We do. And this is nothing. So paying attention to where you are is because they do impact. And if there's something that's wrong with your environment that you notice, that's not getting cleaned, you notice a lot of smells, whatever, you need to report these things, right? And put your voice out there. Strongest way is to make it heard, especially to those in politics, because they need your vote.
All right, we're going to wrap this up. If there's lunch afterwards, and so you have a chance to interact with our panel members. You notice the way I did that exercise thing? Okay, good. I was watching. Now, so we're going to wrap it up, but I want each one of our panel members to give us one take-home point that you want us to have. It's got to be short now. One take-home point that I want you to get. But before we do that, I want to remind you, if you've not filled out part 1 of the survey, please fill that out. And then, of course, if you have, I want part 2 filled out. At the end of it, you can give it to anybody from HEAL, and there's Ms. Gabriel Jones, who's standing up there. Shayla, please stand up. Ms. Mildred Pierce, please stand up. These are all people from HEAL that are here to help us all. Let's give them a hand anyway. But they really organized a great program, didn't they? And let's also give a hand again to AstraZeneca. I don't think you all realize. I mean, let's be real about this. You have, as Mr. Mosby said, you got a multi-billion-dollar company. Billion. That's more than Elon Musk claims he saved us. But I'm not going to use bad words in your church. So. Now, but let's think about that. How many of you can name me a pharmaceutical company? Yeah. But just think, you got an international company that has come to your house. Let's give it up for them. Give it up for them. So when you hear these things, well, the pharmaceutical industry doesn't care about me. Well, some of them might not, but at least you know one that does. All right, Ms. Cartagena, what's the take-home point?
Together we can change the future. That's the top point.
Dr. Long, keep going.
My take-home point as a pharmacist, take your medication, and if you can't, talk to your healthcare provider about why and come up with a plan B.
My take-home point as a physical therapist is to just get up and move a little bit more throughout the day. And also in Alabama, you don't need a referral from your physician to see a physical therapist. So if you have any aches, pains, strains, come see us.
My take-home point, being a heart failure practitioner, is know your numbers. What's your blood pressure? What's your cholesterol? What's your weight? What's your blood sugar? So know your numbers.
Along the same lines, I would say is know your body. and be able to advocate for it. Because a lot of these diseases, they come along subtly, and these little bitty changes sort of build up until you have this big turning point. And often at that time, it's a little bit too late. So advocate for it and know your body.
Building on what they shared, know your body, set some goals, make the change as an individual, and then help others to make a change for your family and then in your community.
Thank you all for, let's give the panel a hand. You know, there are many things that we can do for ourselves, and sometimes we need a little bit of help. But I think you see right now, there are a lot of resources here in Birmingham, Alabama. Please reach out for them. Let's turn things back over to the good Bishop Hammond. And as I said last time, I'm going to say it this time. The only thing standing between you and lunch is Dr. Hammond.
I am Dr. Q.E. Hammonds. I am a graduate of Alabama A&M University, where I got my BS degree in history and political science. I have a Bachelor of Divinity degree from Antioch Baptist Seminary, a Master's of Divinity degree from the Universal Bible Institute, and 2 honorary doctorate degrees, 1 Doctor of Divinity degree from E.L. White Theological Seminary, and a Doctor of Letters degree from Antioch Baptist Seminary. So since everybody gave their credentials, I just thought I'd give my credentials since everybody giving their credentials. Seriously, saints, please fill out these forms, these survey forms. We need them because AstraZeneca, our sponsor who is here today, you know, we always hear about Big Farm this and Big Farm that. Big Farm is here today. And it's showing that they care about us in our community. And we want them to know that that we've been here. So the only way they're gonna know that you've been here is for you to fill out these forms and turn them in. Please, ma'am, please, sirs, look in your packet and get this form right on the left-hand side. Fill it out and turn it in. I want to thank Heal Collaborative, Howard and Gabrielle for their hard work, because they put this panel together. They put this panel, and these are experts in their field, and they're coming out here to talk to us. Amen. Amen. Now, give your pastor a hand for knowing how to contact the folk that can contact people. And Dr. Long, I got a question for you, but I'm ashamed to ask it in front of folks, so. Okay, all right. Now, please go, lunch is ready. We're gonna do just like we did last week. For the seniors, you'll be served downstairs, and for the adults, for those who are able, go upstairs in the J.R. Walker building. And I told you, I promised you that Antioch would have just a little gift for you for coming out. So those of you who were here last time and are here today, Antioch Missionary Baptist Church Incorporated, the 1220 Hattie Street, Birmingham, Alabama, has a $25 gift card for you. Amen. That's right. And go. That's right. Go to Carver Jones with it, because I've been there, and I'm very pleased with what I got when I was there. And all right. Thank you all so much, Antioch. Yes, ma'am. Up there, Lavinia, Stephen. All community health workers that are in the building. Sister Lavinia wants to see you after we dismiss. Thank you all so much for coming out and it was worth it, wasn't it? Thank you to the speakers. My heart is just full of joy this morning. And for those of you who don't know, I talked about at the top of the program that pretty black girl that I married. There she is right there. Stand up, baby, stand up. I want them to see that's who I asked the Lord for right there. And he answers prayer, hallelujah. All right, we're going to stand now for, woo, talk, daughter, talk. Let the Lord lead you. All right, okay. We're going to bless the food and give the benediction. And to all of our visitors, thank you all for coming, people of this community, because it's more than Antioch in here. But if you were here last week and you're here this week, this gift is not just for Antioch members, okay? We have one for you, and we're going to give them out at lunch, so please go over and have lunch with us. Lunch has been prepared by Chef Brandon Hicks and Kay Shanae, caterers, and he always has something good for us. All heads bowed. Lord, we thank you for today. We thank you for what our eyes have seen, our ears have heard, and our hearts have felt. Lord, we ask your blessings upon these presenters. We ask your blessings upon our sponsors. We ask your blessings upon those who were integral in getting these people to us to give us this information. Now, Lord, bless the food that has been prepared for the nourishment of our bodies. Do that, Lord, as your word nourishes our spirit. In Jesus' name we pray. Amen. Don't forget to set your clocks up tonight.